It is my pleasure to introduce Dr. Mele. He is a third-year internal medicine resident. He completed his bachelor's degree in biology at Lehman College of the City University of New York and his master's degree in biological and physical sciences at Touro College. He attended medical school at the American University of the Caribbean School of Medicine, and he is pursuing a career in hospital medicine. Join me in welcoming Dr. Mele.
Hello, good afternoon, everyone. I will be talking today on in adult mineralocorticoid receptor antagonists reduce atrial fibrillation occurrence versus non-MRAs. I have no conflict of interest to declare. The learning objectives for this talk will be to discuss the current use of mineralocorticoid receptor antagonists in treating patients with heart failure, analyze the systematic review and meta-analysis providing evidence that MRAs reduce new onset and recurrent atrial fibrillation, review the role of MRAs in prevention of inflammatory atrial fibrosis, review the need for future randomized controlled trials measuring different outcomes, such as incident atrial fibrillation, recurrent atrial fibrillation, and burden of atrial fibrillation. MRAs in heart failure patients. MRAs have been shown to reduce morbidity and mortality in patients with heart failure with reduced EF and EF less than or equal to 40%. In patients with heart failure with mildly reduced EF and with EF between 41 and 49%, MRAs reduce the risk of heart failure hospitalization and cardiovascular mortality. In patients with heart failure with preserved ejection fraction, MRAs may decrease hospitalization. The contraindications to MRAs use include potassium level more than 5 and estimated GFR less than or equal to 30, pregnant patient or those hoping to become pregnant, and it is not recommended to use in combination with ACE inhibitors and ARBs due to risk of hyperkalemia and renal dysfunction. When patients are on MRAs, it is recommended to monitor potassium level, renal function, and diuretic dosing to reduce risk of renal insufficiency and hyperkalemia. The frequency of monitoring is based on clinical status, such as 1 week, 4 weeks, or 6 months after initiation of MRA or with dose increases. And it is recommended to discontinue if potassium cannot be maintained less than 5.5. What is the effect of MRAs on atrial fibrillation? AFib is the most prevalent heart arrhythmia. The worldwide incidence and prevalence of AFib have increased threefold over the last 50 years. The global prevalence was estimated to affect a population of 37.5 million in 2017. There is a debate over the significance of MRAs in reducing the risk of AFib, and some studies have shown inconsistent results. In adults, then what is the effect of MRAs versus non-MRA drugs or placebo on atrial fibrillation outcomes? To answer this question, we are going to review this article that was published in the American Journal of Cardiology in 2023, a systematic review and meta-analysis on effectiveness of mineralocorticoid receptor antagonists in reducing the risk of atrial fibrillation. This study was performed under the preferred reporting items for systematic review and meta-analysis guideline. A comprehensive search was conducted using PubMed, Embase, Cochrane Central from their inception to September 2021 without any language barrier. And the search included the following keywords that you can see here. The inclusion and exclusion criteria for the study. For the study design, the inclusion criteria include phase 3 randomized controlled trial and randomized placebo-controlled trials, a population age more than 18, and the comparison was between MRA versus non-MRA agents. The outcome was AFib events, and the publication type was full-text article. Excluded from this study were observational studies, case report, case series, cross-sectional studies, patients with age less than 18 years, comparison between other antiarrhythmic agents, and protocols only as publication type. This chart is illustrating how they were able to filter the studies, that the result of their search, and come up with the last 10 studies that were included in the systematic review. We can see the identification, screening, eligibility, and inclusion phases. That resulted in 5 randomized placebo-controlled trials, 3 randomized controlled trials, 1 multi-center randomized controlled trial, and 1 single-center randomized controlled trial. This study was reviewed by 2 independent researchers. A third reviewer was consulted to sort out any inconsistencies. The modified Cochrane collaboration risk of bias tool for randomized controlled trial was used to evaluate the quality of trial. The chi-square was used to assess the differences between subgroups, and Huygens was applied to assess the heterogeneity, and the value less than 50 for Huygens was considered acceptable. And a p-score less than 0.05 was considered significant in all cases. The 10 studies that were included comprise 11,356 adult patients. The mean age of the entire population in the study was 66 years. Of the 11,356 patients, 50.1% were on the MRA therapy group, and 49.9% were in the non-MRA therapy group. Among the 5,693 patients who received MRAs, 15.9% received spironolactone, 9% received eplerenone, 0.2% received canrenone, and 24.9% received finerenone. Most of the patients, 87.3%, did not have an history of AFib at the time of enrollment. And the mean left ventricular ejection fraction in the study was 45.3%. The meta-analysis of all the included studies demonstrated that patients who were treated with MRAs had a 23% risk reduction in occurrence of AFib compared to non-MRA therapy, with a relative risk of 0.77, a 95% confidence interval of 0.65 to 0.91 that excluded the null value of 1, and a significant confidence statistically significant with a p-value of 0.03, and Huygens less than 50%. 6 studies involved patients without heart failure, 49% in the MRA group and 50% in the control group. 1 study included patients with heart failure with preserved ejection fraction, 50.1% in the MRA group and 49.9% in the control group. 3 studies included patients with heart failure with reduced ejection fraction, 50.4% in the MRA group and 49.6% in the control group. And the effect of MRA on AFib was different in subgroup. As you can see, in patients who did not have heart failure, the relative risk was 0.74 and a confidence interval of 0.65 to 0.84, and the data was statistically significant. Same was in the patients with heart failure with reduced EF with a relative risk of 0.61, a confidence interval of 0.42 to 0.89, and a statistically significant data. However, in patients who were in the heart failure with preserved ejection fraction, the relative risk was above 1, and it did not show a significant decrease in this subgroup. A significant decrease in occurrence of AFib in this subgroup. The 6 studies reported the effect of MRAs on new-onset AFib as well, with 50.3% in the MRA group and 49.7% in the control group. And 4 studies reported the data on the effect of MRA therapy on recurrence, with 50.2% in the MRA group and 49.8% in the control group. MRAs were found to reduce the risk of both new-onset AFib with a relative risk of 0.84 and recurrent AFib with a relative risk of 0.73. Those tables summarize the study and baseline characteristics that were previously discussed, along with the comparison and the EF of the patient involved, the mean age, the primary or secondary AFib prevention, and the population that was involved in the study. And this figure summarizes the impact of MRAs versus control on AFib occurrence. We can see that the relative risk of 0.77 and a confidence interval between 0.65 and 0.91. In summary, in adult, MRAs reduce AFib occurrence compared to non-MRAs or placebo. And so how does that happen? What is the mechanism of action by which this happens? Aldosterone contributes to the development of atrial fibrillation through inflammatory atrial fibrosis. Aldosterone has also been found to raise interleukin-6, which along with interleukin-1 and tumor necrosis factor alpha have been reported on clinical examination of patients with atrial fibrillation. Furthermore, aldosterone increases the expansion of connective tissue growth factor and a profibrotic factor in AFib and collagen production. Angiotensin 2 through the renin-angiotensin-aldosterone system incites oxidative stress and increases the generation of reactive oxygen species in the vascular system. Aldosterone antagonists down-titrate aldosterone and angiotensin 2 level. MRAs also promote the activity of ACE, thus converting angiotensin 2 into a less active form of angiotensin 1. The combined effect on volume control through diuresis and blood pressure reduction may reduce strain on the heart, particularly the left atrium. This diagram is explaining what aldosterone excess can result in. A few of them is endothelial activation that can further down the road lead to myocardial infarction. It can result in interstitial inflammation and collagen deposition that lead to systolic heart failure. It can result in hemodynamic overload, myocardiocyte hypertrophy that leads to diastolic heart failure, and it can result in atrial remodeling, calcium overload, triggering activity and reentry, and atrial fibrillation. Some of the limitations of the study were that the trials were conducted on different MRA agents, and given the limited number of trials per MRA, the authors did not perform a subgroup analysis to analyze the individual efficacy of each MRA. The trial pool varied in study design, cohort, and follow-up durations. There was only one study available on AFib in patients with heart failure with preserved ejection fraction, and more trials are needed to evaluate the effect of MRAs on AFib in this population. So the take-home point and how this can be applied in clinical practice is that in this study, 87% of patients did not have AFib at the beginning of the study. So if MRAs are able to prevent AFib, this will be a game changer because we could start those on our patients who have resistant hypertension, and in that way we could prevent the occurrence of AFib down the road. We also know that MRAs are used in the treatment of heart failure with reduced ejection fraction, and whenever our patients come in with this condition, if they do not have any contraindication to MRAs, they should be started on them. I have a question here, if anyone wants to read it.
A 47-year-old male is evaluated for management of heart failure with reduced ejection fraction, 30% diagnosed 3 years ago. He has a New York Heart Association functional class 3 symptoms, and he's been stable for the past year. His medical history also includes ACE inhibitor-induced angioedema, spironolactone-induced gynecomastia, atrial fibrillation. An implantable cardioverter defibrillator is in place. Medications are losartan, carvedilol, empagliflozin, furosemide, and apixaban. On exam, his blood pressure is 120/68, pulse rate 78, and irregular. Other than an irregular heart rhythm, the remainder of the exam is normal. Serum creatinine and electrolytes are also normal. Which of the following is the most appropriate treatment? You got A, eplerenone, B, add eplerenone, B, add ivabradine, C, switch carvedilol to metoprolol succinate, or D, switch losartan to valsartan sacubitril.
So if the patient is having spironolactone-induced gynecomastia, then you can try something like eplerenone instead, because that doesn't cause gynecomastia and you can still use an MRA.
Yeah. So the correct answer is A. Aldosterone antagonist therapy such as spironolactone and eplerenone is indicated in all patients with symptomatic heart failure with reduced EF and normal kidney function to improve survival. And in patients who also do not have, who have gynecomastia, you could use alternative agents such as like eplerenone for those patients.
All right, thank you, Ange. That was an interesting topic. I haven't seen MRAs indicated for AFib, but it makes sense given their indication for heart failure and their AFib's association with heart failure. Seems like the GDMT, it's all kind of based upon ejection fraction, the mildly reduced and reduced benefiting from these 3 to 4 agents. And you noted the one study on HFpEF where there wasn't a benefit. So maybe you could elaborate on if you feel like this is all just benefiting ischemia, atherosclerosis-driven heart disease, heart failure, or if there's another benefit you're getting from MRAs.
Yes, that is a very good question. The use of MRAs down the road decreases the occurrence of atrial fibrosis, and by reducing inflammatory markers that are going to later down the road lead to AFib. Also, there is also a role of volume management and decreasing the strain on the left atrium that helps prevent the occurrence of AFib as well. I believe that more studies need to be done in this patient population with heart failure with preserved EF because only one study was included in the systematic review on that patient population. So the size was very small compared to the other ones. And I believe MRAs in the future will be used in the prevention of AFib given that they are able to decrease the occurrence of atrial inflammation and help with volume management as well.
Thanks, Dr. Mele.
Thank you.